Hi, my name is Huri Leblebjian, and this is the presentation on the advancing treatment horizon for refractory multiple myeloma. I have nothing to disclose. The objectives are to state the epidemiology and burden associated with multiple myeloma. We will examine the evidence on new and current treatment options for multiple myeloma, but it's going to be more concentrated on refractory myeloma. Again, on the outline is just we're going through what is multiple myeloma management, but in addition, I will talk about some adjunctive therapy and some of the future therapies because there's so many studies going on. So what is multiple myeloma? It is the malignant neoplasm of plasma cells. So this is the differentiation pathway for stem cells, and as you can see, they go from blood stem cells to either myeloid or lymphoid stem cells. Then the lymphoid stem cells get into lymphoblast, and the lymphoblast can go into natural killer cells, T lymphocytes, or B lymphocytes. And the B lymphocytes differentiate more into plasma cells, and that is what's multiple myeloma, the neoplasm of plasma cells. So what do plasma cells do? They produce immunoglobulins, which consist of a heavy chain, as you can see in the picture, IgG, IgA, IgM, IgD, or IgE, and light chain, kappa or lambda. So when plasma cells, they become cancerous, they're unable to produce antibodies to fight infection. And this is called monoclonal gammopathy, which is the cloning of the same immunoglobulin. So what the cells would start doing is produce from the same antibody over and over again, but that antibody cannot help to fight infection. In addition, when they are cancerous, they will crowd the bone marrow, and this will cause the other cells in the bone marrow, the white blood cells, the red cells, to decrease in production, and that can lead to anemia, thrombocytopenia, and leukopenia. Another thing would be myeloma cells, they would increase the osteoclast activity. And this is, they think that there's a number of cytokines and growth factors produced either by multiple myeloma cells or the bone marrow stromal cells that are implicated in increasing the osteoclast activity. And in addition, when we have increase in osteoclast activity, there is no increase in osteoblast activity, and this would lead into hypercalcemia, bone loss, and fractures. Multiple myeloma is the second most common hematologic cancer after non-Hodgkin's lymphoma. The American Cancer Society estimates around 22,000 new cases during 2012, with almost half of those patients dying. The lifetime risk of getting multiple myeloma is 1 in 150, and the median age of diagnosis is 69 years old. It is not considered curable, so even when patients have excellent response to first-line induction therapy, they will eventually experience disease relapse and require further therapy. That's why it's not curable. The 5-year relative survival rate is around 40%, and it's more common in African Americans. The clinical presentation of multiple myeloma is known by the CRAB criteria. C standing for calcium, so these patients will have hypercalcemia because of the increase in osteoclast activity. Renal dysfunction, and this is due to the light chains that sometimes accumulate in the renal tubules. Anemia, as we said, because of the increase in crowding of the plasma cells and the IgGs or the IgM. In the bone marrow, patients will have anemia, and bone disease, which is lytic lesions. The risk factors for multiple myeloma are monoclonal gammopathy of undetermined significance, MGUS. MGUS is when patient has less than 3 grams per deciliter of monoclonal gammopathy with less than 10% plasma cells in the bone marrow, and the patients are asymptomatic. Around 1% of people more than age 50 have MGUS, and the progression rate is 0.5 to 3% per year, progressing from MGUS to multiple myeloma. Another risk factor is being male, age more than 65, as we said, African Americans more than white, exposure to radiation, but studies are inconclusive about the environmental causes, and family history. So individuals with first-degree relatives have 3.7-fold increase in developing multiple myeloma. The diagnosis of myeloma, there are two types. Could be smoldering, which is the stage before active myeloma. The smoldering myeloma is when patients start having monoclonal protein more than 3 grams per deciliter, and or the bone marrow clonal plasma cells are more than 10%. As we said before, the MGUS is the stage even before smoldering myeloma, where patients have less than 3 grams per deciliter of monoclonal protein, and when they have less than 10% bone marrow clonal plasma cells. And in smoldering myeloma, patients do not have any end organ damage or any symptoms. Active myeloma is where there's the presence of serum or urine monoclonal protein and the plasma cells in the bone marrow are more than 10%, and they have one of the following criteria: elevated calcium, if they have renal insufficiency, anemia, bone disease, or any other symptoms. The staging of myeloma is, there are two staging systems, the Dury-Salmon system and then the international staging system. The international staging system has only two criteria in it: the serum beta-2 microglobulin, if it's less than 3.5, or if the serum albumin is more than 3.5 gram per deciliter, then that's only stage 1. Stage 3 is we only look at serum beta-2 microglobulin. If it's more than 5.5, it's stage 3. And stage 2 is neither stage 1 or 3. And what is beta microglobulin? It reflects tumor mass and is considered a standard measure of the tumor burden, which is produced by malignant cells. It's only indication of prognosis, and by the levels increasing, for example in stage 3, it means the disease is worse. Subclassification criteria for myeloma are A or B, A being if the patient has a normal renal function, and B if they have an abnormal renal function. This is the response criteria. It is done by the International Myeloma Working Group, and there are so many criteria in it. The first is the stringent complete response. This is when patients have normal free light chain and they have no clonal cells in the bone marrow by immunohistochemistry or immunofixation. Complete response is when patients have less than or equal to 5% cells in the bone marrow. The very good partial response is when they have more than 90% reduction in M protein. Partial response is when they have more than 50% reduction in the M protein. Stable disease is when they do not meet criteria for the above, and progressive disease is when they have more than or equal to 25% increase in their M protein. Management. So this is a slide where it shows where did we go in multiple myeloma. As you can see, in the 1960s to 70s, prednisone and melphalan were the only agents. They're used until now, but there are so many new agents that came afterwards. In the mid-1980s, autologous transplantation started being used in multiple myeloma. And then by the year 2000, we had thalidomide and bisphosphonates being used. And as you can see, by 2010, we have lenalidomide, we have bortezomib, and now in clinical trials, second-generation proteasome inhibitors, the second-generation IMiDs, HDAC inhibitors, and monoclonal antibodies. So this is how we treat patients when they're first seen. So diagnostic evaluation is done with all the scanning and all the lab tests. And then we decide if these patients are symptomatic, stage 2, 3, or smoldering or asymptomatic stage 1 myeloma. If they're smoldering or asymptomatic stage 1, they are usually observed at frequent intervals. If they are symptomatic, we should decide first if these patients are eligible for transplant or not, and eligibility is mostly based on comorbidities. like age, their renal function, their other diseases, if they have diabetes, heart problems, renal problems. So if we decide that this patient is eligible for transplant, they will get an induction therapy, and then after induction therapy they will have a transplant. And after transplant, if they are not on maintenance therapy and they're followed, they might relapse and they will need salvage therapy. If these patients are not eligible for transplant, they will still get an induction therapy, but then we can put them on a maintenance therapy and wait until they relapse, and then they would need salvage therapy. These are some of the regimens that are used for multiple myeloma in the transplant candidate patient, for non-transplant candidate, and for maintenance therapy. As you can see, bortezomib, Velcade is a big part, and it is included almost in every regimen. The only difference with as you can see, is that in the non-transplant candidate, we can use melphalan more because these patients do not need to be stem cell mobilized, while in transplant candidate patients, we don't like to use stem cell toxins like melphalan. Now we're going to start talking about relapsed refractory disease. So what is refractory myeloma? The definition is disease that is non-responsive while on primary or salvage therapy or progresses within 60 days of last therapy. Refractory, there are two categories of it: the relapse and refractory myeloma. These are within patients who achieve a response and now they're refractory to their disease. And primary refractory are patients who fail to achieve any response to initial anti-myeloma therapy. The median survival after first relapse is less than 2 years, and currently there's no standard treatment, so there are a combination of regimens and we can alternate and use any one of those. And based on disease and patient-related factors, we will decide what is the best treatment for these patients. So disease-related factors are duration of response to initial therapy. If the patient had a longer response to that therapy, we can repeat it. Some of the other things we look at is FISH and cytogenetics. So for high-risk myeloma patients, if they have translocation 414 or translocation 1416, deletion 13q, and deletion 17p, these patients have more aggressive disease and poor prognosis, so these patients need to be treated more aggressively. Another factor we look at is regimen-related. Did these patients have prior drug exposure? Do they have any toxicities of that regimen, which means we cannot use the same drug? The mode of administration, if some patients prefer oral versus IV drugs, and if these patients had a previous stem cell transplant, if we're thinking of doing another transplant or not. And patient-related factors are if patients had pre-existing toxicities to any therapy, if they have any comorbidities, their age, and their performance status. So for early relapse patients, we think about either lenalidomide-based therapy, if they had their initial therapy with bortezomib, and if they have an underlying peripheral neuropathy. We think about bortezomib-based if they initially had lenalidomide or thalidomide, if they had a longer duration of response with previous Velcade, and if they have any renal dysfunction. And then we'd consider transplant if these patients didn't have a previous transplant or they had a long remission post their transplant. And always we consider clinical trial with a novel agent for these patients too. For aggressive, rapid, or multiple relapse patients, we think about a chemotherapy-based salvage with chemotherapy, DSAP or DT-PACE. We can think about oral versus IV chemotherapy, and in these cases, performance status will play an important role. Or we can think of a stem cell transplant-based salvage, but if these patients have aggressive disease and they have multiple relapses, probably it's going to be short-lived. Or we can think about a chemotherapy plus novel agent. This is what clinical trials a lot of time are looking at, combination of lenalidomide and or Velcade with other new agents. So some of the salvage therapy is using conventional chemotherapy, high-dose melphalan with methylprednisolone, or the VAD regimen, or the DSAP, DT-PACE. The newer therapy, the newer agents and combinations are more easy to tolerate, and these include Velcade with liposomal doxorubicin, or even Velcade with Dex. This is all going to depend on the patient preference, if the patient side effects that they had before, and if they had a good response to any one of these regimens and they had a longer duration of response. So we're going to start to talk a bit about bortezomib. Bortezomib is a synthetic boronic acid dipeptide. It's a reversible inhibitor of the 26S proteasome, and it's first in the class of proteasome inhibitors. So this is the mechanism of action of bortezomib. So the ubiquitin proteasome system is responsible for maintaining protein homeostasis through timely degradation of intracellular proteins. So basically it acts as the body's garbage disposal. What bortezomib does, it inhibits the 26S proteasome, and these unneeded protein stay in the cell, and eventually the cell will die because they should be disposed. So multiple myeloma, they have an upregulation, multiple myeloma cells have an upregulation of this ubiquitin proteasome pathway. That's why they are more sensitive to proteasome inhibitors. In addition, Velcade also appears to inhibit angiogenesis and suppress interactions between the multiple myeloma cell and the bone marrow stromal cells. Some of the adverse effects of Velcade are peripheral neuropathy. It's reversible in most cases with the interruption of therapy or dose modification. That's why it's very important for patients to let their providers know once they start having peripheral neuropathy to start dose reductions. Another side effect is thrombocytopenia. Some of the GI side effects, diarrhea, nausea and emesis, constipation. And an important thing with Velcade is the increased risk of herpes zoster virus reactivation. So mechanism of action of this reactivation is not fully understood, but it could be due to Velcade effect on CD4 positive T cells. So these patients always need to be an antiviral prophylaxis. And there are some other rare side effects, lung injury, pulmonary fibrosis, and others. So some of the initial phase 1 and 2 studies demonstrated around 25 to 35% response rates in relapsed refractory disease with Velcade. And as you can see in this table, these are some of the combination studies. So this is a combination of Velcade with Cytoxan and dexamethasone, and as you can see, it gives median overall survival of 22 months to 24 months with more than PR of 82 and 68%. Another combination is the use of Velcade with doxorubicin and dexamethasone, and again this gives more than PR rates of 67 and 85%. And the combination of Velcade with melphalan or Velcade melphalan with Dex, again with good PR rates. This is this first study, the APEX trial, that got the approval for Velcade. This trial looked at Velcade versus high-dose dexamethasone for relapsed refractory myeloma. It included 669 patients. And as you can see, the complete response plus partial response rate were much better and statistically significant with the Velcade versus dexamethasone, and the overall survival, again, was statistically significant. The median overall survival in this study was 29.8 months in the bortezomib arm versus 23.7 months in the dexamethasone arm. And bortezomib was found to be superior to high-dose dexamethasone for treatment of patients with myeloma who had a relapse. This is the study where the combination of bortezomib with pegylated doxorubicin was approved, and it included 646 patients, and the combination showed better overall survival of 76% versus 65%, but of course with increase of side effects with liposomal doxorubicin, which included more hematologic adverse events. The median time to progression was 9.3 months in the liposomal doxorubicin Velcade arm versus the Velcade arm, which was 6.5 months. And the combination of pegylated liposomal doxorubicin and Velcade was found to be superior for treatment of patients with relapsed refractory multiple myeloma. There's also one study, a phase 3 study, that got the approval of the sub-Q Velcade, and this was on 222 patients. It was a non-inferiority trial of sub-Q versus IV, and they found no difference in total time to progression and the 1-year overall survival, and the peripheral neuropathy with subcutaneous Velcade was shown to be statistically lower with the sub-Q in the sub-Q arm. This is now we're going to start about thalidomide and lenalidomide. So the bone marrow microenvironment, it plays a key role in supporting the growth of the myeloma cells by secreting growth factors and anti-apoptotic cytokines like interleukin-6, interferon alpha, and VEGF. So what thalidomide and lenalidomide do, they modulate the expression of cytokines and adhesion molecules such as the interleukin-2, interferon gamma, that stimulate T cells and natural key cells to destroy the multiple myeloma cells. They also downregulate cytokines like interleukin-6 and TNF-alpha that contribute to angiogenesis. Thalidomide was first marketed in Europe in the late 1950s as a hypnotic and antiemetic for treatment of morning sickness during pregnancy, but it came up that it caused a lot of deformities in babies, so they removed the drug. By 1998, thalidomide received orphan drug status and was approved by the FDA for management of erythema nodosum leprosum under the STEPS program. Then in 2006, thalidomide received FDA approval for primary treatment of multiple myeloma in combination with dexamethasone. Lenalidomide was approved in 2005 for the treatment of transfusion-dependent patients with deletion 5q myelodysplastic syndrome, but in 2006 it was approved in combination with dexamethasone in patients with multiple myeloma who received one prior therapy. There's a REMS requirement with lenalidomide, and the difference between lenalidomide and thalidomide is that it is 50,000 times more potent than thalidomide in inhibiting TNF-alpha. In addition to the difference in the potency, there are some differences in the adverse events. Thalidomide has more side effect of fatigue, peripheral neuropathy, while lenalidomide has more side effect of myelosuppression, and it has less neuropathy than thalidomide, less thromboembolism than thalidomide, but both of these drugs need anticoagulation with aspirin. Some of the rare side effects are bradycardia, hypothyroidism, hepatotoxicity with thalidomide, and hypersensitivity pneumonitis with lenalidomide. So a systematic review of phase 2 trials showed that thalidomide monotherapy had a partial response in 30% of patients with relapsed refractory disease. And as you can see, these are the studies that include cyclophosphamide, thalidomide, and dexamethasone with good response rate, partial response rate of around 60% or better. These are the combination studies with lenalidomide. So as a single agent, lenalidomide demonstrated phase 1 and phase 2 studies response rates around 40% in patients who received median of 3 prior therapies. So these are the combinations of lenalidomide, the Cytoxan, and dexamethasone. Another study is liposomal doxorubicin with lenalidomide and dexamethasone. This is a phase 3 trial of lenalidomide with dexamethasone versus dexamethasone alone in relapse refractory multiple myeloma. It was done on 351 patients, and the overall response rate was statistically better with the combination of lenalidomide with dexamethasone, of course having side effect neutropenia being higher too in the combination arm. The median time to progression was 11.3 months in the combination arm versus only 4.7 months. And most of the side effects, in addition to the neutropenia, again were thrombocytopenia and venous thromboembolism. These are some of the combination trials of Velcade with thalidomide-based combinations. As you can see here, we have some of the lenalidomide Velcade-based combinations and lenalidomide thalidomide-based combinations. I just put the slide so that you can see there are so many studies going on, and always the combinations are giving better results, but sometimes the side effects are more too. Adjunctive treatment in multiple myeloma is very important because these patients have these other issues going on in addition to their myeloma, but because of the myeloma, and one of them being the bone disease. So these patients are usually on bisphosphonates, either zoledronic acid or pomedronate. Studies done have not shown one of them being better than the other. Radiation is used as palliation for bone pain. Sometimes patients get vertebroplasty or kyphoplasty for symptomatic vertebral fractures. And one important thing to remember is to monitor for renal function and osteonecrosis of jaw with bisphosphonates. Patients need to have a good oral hygiene, see their dentist, and make sure that their mouth care is okay. So bisphosphonates are usually continued for 2 years. Studies done now are only for 2 years, and these patients would need to take vitamin D and calcium too. Another adjunctive treatment is hypercalcemia. Some patients, because of the increase in osteoclast activity, can present with hypercalcemia, so hydration with furosemide can be used, bisphosphonates again, steroids, or calcitonin. Patients, of course, have anemia, as we said, because of the disease, and if we're treating the disease and these patients still are anemic, erythropoietin is a choice that we can use. So these patients are more prone to infection because their good immunoglobulins are not being produced. They only have the monoclonal gammopathy, which cannot fight infection. That's why it's very important that they get their pneumococcal and influenza vaccination. Sometimes we give them IV immunoglobulin if they have recurrent infections. Herpes zoster prophylaxis, as we talked about with acyclovir or valacyclovir for patients on Velcade, should be continued. And PCP, fungal, and herpes prophylaxis if patients are on high-dose steroids. As we talked about coagulation, lenalidomide and thalidomide increase the risk of patients getting VTEs. That's why it's very important that these patients are on anticoagulants. So some of the individual risk factors for thrombosis include age, history of VTE, comorbidities like diabetes, cardiac disease. These patients are immobilized, surgery, or have an inherited thrombophilia. So some of the options for use are low molecular weight heparins or warfarin. With lenalidomide and thalidomide, aspirin is enough, but if the patients have other risk factors mentioned, then they need to be on the warfarin or low molecular weight heparin. Renal dysfunction with these patients, we just make sure to maintain hydration, avoid toxins like NSAIDs and IV contrast, and monitor the renal function when these patients are getting bisphosphonates. Peripheral neuropathy, as we said, is a big issue with Velcade and with thalidomide. Very important that these patients know, to let their providers know, and once the dose is reduced, we can give them some additional adjunctive therapy like opioids, gabapentin, pregabalin, TCA antidepressants are used too, and then some of the topical lidocaine or capsaicin cream. Vitamin supplements is important too, like alpha-lipoic acid, vitamin E, vitamin Bs. Now there are some new drugs one of the new drugs that was just approved was carfilzomib. Carfilzomib is an irreversible proteasome inhibitor of the epoxytone class. It has a longer duration of inhibition. FDA approved carfilzomib for the treatment of patients with multiple myeloma who have received at least 2 prior therapies, and that should be at least Velcade and either lenalidomide or thalidomide, and who have progressed on or within 60 days of completing their last therapy. This is the FDA approved indication for carfilzomib. So they got the approval based on this phase 2 study of 266 participants with relapsed refractory multiple myeloma. 36% had minimal response or greater, and 24% had partial response or better. And the median duration of response in these patients was 7.8 months. The most common side effects with carfilzomib was low blood count, fatigue, nausea, shortness of breath, and diarrhea. And one of the serious side effects, in addition to the pneumonia, congestive heart failure, there were a couple of patients who had cardiac arrest, so it's very important to monitor and see if patients are having shortness of breath and if it's getting worse. Peripheral neuropathy is very low with carfilzomib, and that's one of the big differences that we see between carfilzomib and bortezomib. Carfilzomib costs around $10,000 for one cycle, which is 28-day cycle at the recommended dose for a patient average size. Velcade costs between $4,000 to $8,000 for a 1 month period, and lenalidomide is around $8,000 for a 1 month period. I just wanted you to see how every time there's a new drug coming up, how it's getting just more expensive. Carfilzomib is also being studied in combination with lenalidomide and dexamethasone. There are some phase 3 trials going on. The Aspire trial comparing carfilzomib, lenalidomide, dexamethasone versus lenalidomide, dexamethasone, and the Focus trial comparing carfilzomib versus best supportive care. So some of the clinical trials out are studying pomalidomide, which is a second-generation IMiD, a second-generation proteasome inhibitor, marizumab and MLN, HDAC inhibitors, panobinostat, vernostat, monoclonal antibodies, elotuzumab, cetuximab, and AKT inhibitor, periphosin. So I'm going to talk a bit about these drugs. Pomalidomide, as we said, its mechanism of action is almost the same as the lenalidomide, but it suggested that it has some inhibitive effect on myeloma cells in the bone by inhibiting osteoclast differentiation. Some of the adverse effects of pomalidomide are myelosuppression, and it has again less peripheral neuropathy than thalidomide, but still the VTE risk is still there. So these patients would still need DVT prophylaxis. Marizumab and MLN are both new generation proteasome inhibitors. Marizumab is IV, MLN 9708 is an oral proteasome inhibitor. Some of the side effects with marizumab seen are hallucination, some of the neurotoxicity side effects with it. And with MLN, again, effect on hematological, decreased platelets, neutropenia, fatigue, and rash. But peripheral neuropathy is low with both of these drugs. HDAC inhibitors, they work just like the cell has the proteasome pathway to get rid of the misfolded proteins, it has the agrosome pathway. So HDAC inhibitors work on that part and then again remove this T4. So there are so many new drugs in clinical trials now. Pomalidomide is a newer generation IMiD. Its mechanism of action is same as other IMiDs, but evidence suggests that it inhibits destructive effects of multiple myeloma in the bone by inhibiting osteoclast differentiation. Some of the adverse effects are myelosuppression and risk of VTEs, so anticoagulation is still required, but it has less peripheral neuropathy than thalidomide. Second-generation proteasome inhibitors, marizumab is an IV form of proteasome inhibitor. Some of the adverse effects of are neurotoxicity, fatigue, but it has no peripheral neuropathy and no thrombocytopenia like Velcade does. MLN9708 is an oral proteasome inhibitor. Some of the common adverse effects are thrombocytopenia, neutropenia, fatigue, rash, and again the peripheral neuropathy rate is very low. HDAC inhibitors, panobinostat and voinostat. So the cell has two ways of getting rid of their misfolded proteins: the proteasome pathway, which Velcade affects, and then the agrosome pathway, which the HDAC inhibitors work on. Panobinostat and voinostat most common side effects are hematologic side effects and fatigue. The monoclonal antibodies elotuzumab, it targets the cell surface adhesive molecule CS1 that is expressed on majority of multiple myeloma cells. And the most common adverse effect is hematologic side effect, while cetuximab is an anti-IL-6 antibody. The AKT inhibitor periphosin, it inhibits the AKT phosphorylation that downregulates the signal transduction via the PI3 kinase AKT-mTOR pathway, which is a key regulator of cellular growth and survival. So basically it's working on the signaling pathway of the AKT-mTOR and inhibiting the signal transduction. Common side effects with periphosin are GI side effects, fatigue, and hematological side effects. This is just a slide talking about the combination of these newer agents with some of the agents that are already approved, and it just talks about, it shows different mechanism of actions of each one and how the combination of these regimens can be really targeting the myeloma cells from different directions. So if we want to talk about management strategies, as I said, there's no data outlining the most appropriate sequence of treatment in relapsed multiple myeloma, relapsed refractory multiple myeloma. There are factors to consider is the timing of relapse, the comorbid conditions, and once patients have a resistance to one drug, it doesn't exclude that combination. If the patient, we can always use that drug again in combination with another agent if the patient's duration of response was a longer time. So in conclusion, multiple myeloma is a malignant neoplasm of plasma cells that accumulate in the bone marrow, leading to bone marrow destruction and marrow failure. The new therapies that are being used have increased the long-term survival, and it's very important that we use combinations of approved drugs and newer agents in clinical trials. But despite all this, multiple myeloma needs newer drugs to overcome the high relapse rate and refractory disease associated with it. Thank you.